Even as daily case numbers improved this week, Ontario hit a grim milestone. More than 6,000 people have died from COVID-19 as the second wave's toll outpaced the first wave. But as new modeling showed, there is hope, and much of it comes from our experience and the incredible work of public health and medical science. With us for the latest in Mississauga, Ontario, Dr. Zain Chagla, Associate Professor in the Department of Medicine at McMaster University and an infectious disease specialist at St. Joseph Healthcare Hamilton. And in North York at Sunnybrook Health Sciences Centre, microbiologist and infectious diseases physician, Dr. Samira Mubareka. And Dr. Isaac Bogoch, infectious diseases physician at the University Health Network and a scientist based out of U of T and Toronto General Hospital, where we find him today. Hello to all of you. Thank you so much for making time for us. We know that your schedules are so busy, so thank you for being here.
My pleasure.
So what a year it's been. We find that we have a vaccine, a few vaccines, and we think that we are at the finish line. And then now we find out that there are different variants of COVID-19. Sheldon, if you could please bring up this board. The UK variant, also known as B117, the South African variant, or 1.351, the Brazilian variant, or P1, and one more you may not have heard about, the California variant, or Cal20C. Dr. Mubareka, what do we know about the California variant?
Well, we know the least amount about this particular variant because it hasn't been around or it hasn't been identified and characterized as much as the variants that were originally detected in South Africa and in the UK in particular. And also the Brazilian variant is probably one of the newer ones on the scene. So some of the data that's available now, we know around transmissibility, for example, for the variant detected in the UK initially, because it's been around longer, initially detected in September, and subsequently has spread and become dominant in the UK. And that was a clear signal early to mid-December that something was going on. And that's when the UK shared the data that they had and very quickly made it known that this was a variant of concern. So initially they were called variants of interest. Now they're variants of concern. And most of the concern is attributable to the fact that they likely, almost certainly, have enhanced transmissibility. So this is established for the UK variant and also the one originally detected in South Africa. Less data around the ones detected in Brazil and in California, but we anticipate potentially similar phenotypes.
And Dr. Mubareka mentioned the UK variant, Dr. Bogoch. Should we be surprised that the virus is mutating?
No, not at all. We know that's what viruses do, and it's completely expected. In fact, as Dr. Mubareka mentioned, there are these variants of concern that were discovered in these countries. But if there was the capacity to do the special test that's called the genomic sequencing all over the world, you would find variants of concern popping up likely everywhere. As the virus mutates, it's going to change with time. And it's interesting that, and I know Dr. Mubareka could probably speak to this better than most of us on the panel, there's a certain pattern that we're seeing of these mutations that are happening in distant countries independently of each other, but to the same part of the virus.
What is that pattern?
This is something.
Sorry?
Yeah, there certainly is. I mean, you look at the part of the virus where the mutations are happening that are changing how this virus spreads. It's a part of the virus called the spike protein, and the spike protein is an essential part of the virus that really helps it attach and get into our cells and infect us. So it's kind of interesting that this is happening. It really is no surprise. In fact, if people like Dr. Mubareka and Dr. Chagla on this call, and myself and many others who have commented on this have been talking about these mutations that were very likely going to happen ages and ages ago, because that's what viruses do.
Do we know how many of the UK variant we have in Ontario right now, Dr. Bogoch?
It is being counted, but I would say that it is an undercount. So currently, I think the official numbers are in the 40s, but it's likely way higher because of a recent outbreak, for example, at a long-term care facility near Barrie. And quite frankly, we are seeing evidence of community transmission of this variant. So there's what's detected, and then there's what's actually happening on the ground. And what's detected is probably a small percentage of what's happening on the ground. It's not entirely clear what the delta is going to be between detected and actual, but it's here. it's certainly here. And here's one thing. I know that it is likely more transmissible. I think people are sort of debating to what extent it's more transmissible, but I think it's pretty much agreed upon that it is more transmissible. But here's the other part of the story is that, yes, it is more transmissible, but it doesn't mean that it's impossible to stop. So if you look at the United Kingdom, for example, they had this huge spike in cases just before Christmas time. And like their healthcare system was getting overwhelmed. But they took conventional control measures, were able to lock down, were able to basically limit the number of contacts people were going to have in a day. And you watch those cases plummet. So it's not like this has to take over and has to overwhelm our healthcare system. We already have the tools to keep this at bay.
Well, I think that gives people a little bit of hope. And I want to follow up with something that you just said about why it's transmissible. Dr. Chagla, what mutated in this new variant to make it so much more transmissible than SARS CoV-2?
Yeah, so again, these are mutations within the original SARS CoV-2 strain, and these are functionally within the spike protein. So a single amino acid or a single building block of those proteins seem to have swapped in a position. We hear about 501, which is the major mutation that's been noted in B117. There are some theories about biologic plausibility of why this is more contagious. There are some preliminary studies looking at things like viral load in people, especially in the respiratory tract when they're infected by this mutant. And so, yes, it's not necessarily more transmissible, but the person who has it has more virus. There are also some studies looking at receptor adherence. So when the virus actually hits you from an exposure, does it bind to the respiratory tract at a higher affinity than before? So the actual transmission, the events that lead to me infecting you are exactly the same. It's that, either the source is a higher infectious load, or again, the virus adheres to you more. And again, these things get important in the sense that, where we are today, if I have an exposure, there are many things that still protect me along the way from getting COVID. We know in household studies, it's 15 to 20% of people that get COVID, even if they're exposed at a high risk. And that has things to do with viral load, how well the virus adheres to your respiratory tract, the amount of virus in the environment. Those buffers start coming down more and more and more as we talk about these variants. So the transmission is the same, but those events that lead to one having a negative result after exposure that protect one are starting to become less and less and less apparent, and more people will get a positive result after an exposure.
Well, the British Prime Minister, Boris Johnson, has said that it is more deadly. Is it, Dr. Chagla?
So this is based on some of the initial modeling data of death. And so these are 4 different consensus groups that took a look at this. They really did take a look at people that died kind of within the December-January period. It's important to know less than 10% of their deaths from COVID-19 were variants typed. So they really had a small pool of people they were making these assumptions on. The other part is, we're still not sure if there are people that are overrepresented in these death studies. And we can think about what's happening across the country. The people that are more represented in death right now are those in long-term care. And so if B117 were to get into a care facility, you would overrepresent death in that care facility as there would be a larger number of deaths. And so this is emerging data. It's very, very preliminary. It's based on a small data set. There is some data suggesting that the models show increased death at 30% higher. Again, contextualizing it, it would be 10 of 1,000 versus 13 of 1,000, so not a significant rise. But again, these models may have some issues in terms of how they're interpreting this data. And as things start playing out more and more around the world, I think we'll get a better estimate of whether or not this is more fatal or just overrepresented in certain populations.
And Dr. Mubareka, I think when people hear about all these new variants that are coming up, we just found out we have a few vaccines to choose from, and now these variants. How do these new variants affect the vaccines that we have right now?
Yeah, so we're learning a lot more about that. There are a couple of approaches that one could take to try and understand what, if any, impact on vaccine efficacy these variants may have. And it's important to highlight that not all of these variants have the same mutations in the spike protein, though there's a lot of overlap, particularly around between the one that was first identified in South Africa and the Brazilian variant, especially. The UK variant has a 501 change, but not the 484 change. So there may be differences. So that's one thing to highlight. And of course, there'll be differences among people. I mean, one reassuring point is that when we mount an immune response to a vaccine, we don't just make one type of antibody. We make, a repertoire, a number of different antibodies that span the spike protein on antigenic sites. So even if there is reduced efficacy, it's not going to go from, the original 95% or 90% to zero. There'll be potentially a range there, and still most likely, hopefully, there'd be enough antibody for protection. But really, we need to understand that from an experimental perspective. But also, there's some data that's come out fairly recently from a clinical trial just yesterday. It's a press release, so I don't want to overstate it. I don't think that the data has been submitted in full as a preprint, but they are seeing some differences between vaccine efficacy. This is from the UK and from South Africa as well. And the same vaccine seemed to have different efficacy between those two populations, probably based on some of the biological determinants of the variants. Because again, there are 3 changes in the receptor binding domain in the South African variant versus the UK variant. But even within that, different individuals, even with the same viral infection, will have a range of responses. So the bottom line is, number one, ideally we should be testing these vaccines against these variants. Unfortunately, that's not as difficult to do as it was several months ago, because now some of these variants are dominant in the UK and South Africa, respectively. So it's actually not so much of a challenge. But also, vaccine companies are already thinking, like Moderna, for example, about generating boosters. That's the benefit of the technology that's being used, is that it's a little bit more plug and play, making it sound far simpler than it is, but you can replace that spike protein or mRNA depending on what kind of vaccine that you've made. So there is some leeway that the technology allows, and some agility there, but we need to continue to do the surveillance for these variants, and we also need to continue to do the studies to understand to what degree efficacy could be compromised.
And I'm guessing too that, just to go off what you said earlier, Dr. Bogoch, that there's probably more variants that we don't know of. The ones that we do know about, what is it that we must know about each variant?
Well, I think the key thing here is that with the variant discovered in the UK, the issue really is transmissibility, because so far to date, it looks like all of the vaccines that have been developed still provide some decent protection against that variant. But of course, if it is more transmissible and you have community spread, it will ultimately cause significant harm, because at the end of the day, it's going to infect more people, which will result in more hospitalizations, more ICU stays, and more deaths. So community control efforts are key, but also vaccination is key. That's a common theme, because if you look at the other variants of concern, for example, the ones that we know about, like the one that was discovered in South Africa and the one that was discovered in Brazil, the issues with those primarily are surrounding immune escape. And one of the questions is, are the vaccines going to be as effective against those variants, the current vaccines? Well, over the last 48 hours, we now have data on 2 additional vaccines, the Novavax and the Johnson & Johnson vaccine. This is incredible stuff. I mean, like the pace of scientific discovery is just mind-boggling. Like it is, we're cruising along here. And what's interesting is these vaccines don't seem to provide the same level of protection against the variant discovered in South Africa. And initially you think, okay, that's problematic, because it is problematic. You want to have high levels of protection. But when you scratch the surface, and again, like Dr. Mubareka, I've got to be very careful, because a lot of this data is preliminary and it's press release data, and we don't have the full data sets. But when you sort of scratch under the surface, you start to see that it appears that these vaccines are actually, even though people might get the infection, they appear that they will protect against severe disease, hospitalization, and death. And at the end of the day, like, those are kind of the metrics that matter the most, right? Like, look at what was tearing Canada apart and other parts of the world apart. healthcare systems were getting stretched beyond capacity. Long-term care facilities were on fire. We have over 19,000 deaths in Canada, and we saw what happened, for example, in Northern Italy, Wuhan, New York, Houston, other places where their healthcare systems were just getting destroyed. If you can turn a disease that is very, very severe in elderly populations and turn it into something much, much, much less severe, mitigate the morbidity, mitigate the hospitalizations, mitigate the mortality, we'll have done something very, very good. So on the one hand, yeah, sure, we'd love to if these vaccines were more effective against these variants of concerns. That's obvious. But I don't think we should just completely ignore them. They will provide significant benefit. And of course, with the technology that we have now with the mRNA vaccines, it's plug and play. They're already starting to make new mRNA vaccines that will be more effective against these variants. You don't likely need to repeat those phase 1, phase 2, phase 3 clinical trials, which took about a year, actually just under a year to do, which is remarkable in and of itself.
Mm-hmm.
You can likely just modify the vaccine, much like we modify the seasonal influenza vaccine, and mass produce them way faster than you can produce other conventional vaccines because they're mRNA vaccines. And it's likely that at some point, maybe in a year, maybe a little later, maybe a little sooner, we might need a booster vaccine. So it's sometimes in the media, a lot of this is being portrayed as doom and gloom, and the long-term forecast is doom and gloom. I'd like to just separate the politics, separate the ideology, and just look at the data, look at the science. And if you just look at the data and look at the science, it actually paints a decent picture for the spring and the summer in Canada, even when you account for the variants of concern. So, I mean, the key point here now, pardon me for blabbing on and on, but the key points here now are continue to keep the infection controlled in the community and continue to get those cases in a downward trajectory, and then vaccinate. If we can do those two things, we'll be okay.
And it sounds like what you're saying, and honestly, we're so lucky to be able to learn from all three of you. It sounds as if what you're saying too, it's buying us time. And Dr. Chagla, we've been hearing stories of people being reinfected. Have we seen many cases of people getting COVID more than once?
Yeah, there aren't a ton of cases, but they have been well described and well characterized in a different spectrum of illnesses. The initial case was a traveler who had COVID that was mild and was going into another airport region where he had to be retested. It was asymptomatic at the time, but when they do sequencing, much like we're doing sequencing for these VOCs, we see that there's a significant difference between the two strains that the person had. And so really did prove that. There have been hundreds of case reports around the world of reinfection. There's a spectrum of illness, some of it milder, but some of it can be more severe, particularly in areas of the world where there is significant severity. There's a concern here about one of the variants, particularly in Manaus, which is still not proven by any means, but is emerging in a population that had a significant amount of pre-existing immunity based on seroprevalence samples, and may be an example of reinfection, although very, very sketchy data right now. But there are good studies coming out looking prospectively at people, particularly in healthcare settings, that have been infected. And we still know that the rate of getting COVID, again, being reinfected, is relatively low. And in some studies, it actually approaches what we see with these vaccines at 3 to 6 months, where you have nearly 95% of individuals who are serially sampled that don't have COVID. It's somewhere between 80 to 95% on the better studies that have been done to date. So there certainly is reinfection, but there certainly is protection from natural infection. It is not a reason why not to get vaccinated, though. As we know, these vaccines can essentially manipulate our immune systems in a way that is much more controlled, aggressive, and sustainable than a natural infection, and as well knowing what natural reinfection may look like. And so, the recommendation is still that individuals who have been infected to consider getting vaccinated. They can certainly delay it a little bit, knowing that they have pre-existing immunity, But having vaccines available to these individuals still helps with their chance at reinfection in the future.
I want to go back to what Dr. Bogoch was saying about everything that's happened this past year has just kind of been a blur. I read somewhere, and I wish I'd written down the quote, but a scientist had said that in the past 10 years, science has been able to achieve what would have taken 11 years. So, Dr. Mubareka, from the little that you knew, I guess 10 months ago, it feels like years, doesn't it? 10 months ago, how has the treatment of COVID patients changed to today?
Well, just before I answer that, I do have to say we're now referring to COVID time. So 5 weeks in COVID time is maybe 5 months in flu time, and maybe 5 years in terms of time for other fields. It's amazing thinking about what's happened with these variants, and looking back when we initially were alerted, it was 5 or 6 weeks ago, and look at how much has come of that. But similarly for therapeutics, and there have been a couple of approaches for therapeutics. I think out of necessity and not surprisingly, the first thing that people reach for are the known agents. So looking at repurposing agents that are already available and have been tested and are known to be safe in humans, but potentially that are used for something else. The other is to maybe look at some agents that are fairly well along in their development, but maybe not in common practice. Remdesivir would be one good example of that. That was a drug that was, developed for other viruses, but of course it made sense, and there was some great work by Matthias Goethe and others who showed that it could work for SARS-2. So I think that that has been another sort of approach. And then there's the completely different first-in-class approach that people are looking at now. But of course, the range on that is much, much longer. And I'm focusing on therapeutics here. We've already talked about vaccines, but there are also other things that have really progressed significantly. Simple things, what seem like simple things, like how you position a patient in their bed, whether they're prone or not, oxygen administration, use of high flow versus intubating people early, all of these. So a lot of the supportive modalities that we use for these patients has really evolved at a rapid pace over the course of the last 10 months, and I anticipate will continue to do so. And things will be brought on that had initially been discounted. If I recall, early on we were saying don't treat people with steroids, and now people who fit certain criteria are getting dexamethasone. So also part of it is understanding the disease. Initially people were thinking, is this like influenza? It was clearly not like MERS or SARS-1 in many respects. But is this going to look more like influenza? What is this actually going to look like in terms of what we'll call disease phenotype? What kind of complications are patients going to get? So are there interventions that could be targeted against those complications rather than the virus itself? So I'm talking about immunopathology and thrombosis or clotting and things like that. We didn't know what the natural disease would be for a long time, and very grateful for some of the early clinical case series that came out of China, very reliant on the jurisdictions who were first fighting this virus to share that data so that, the therapeutics and the other interventions could follow.
And Dr. Chagla, the Montreal Heart Institute has reported success working with another drug. I hope I pronounced this right, Colchicine. What do you know about this medication? And how do you pronounce it?
Yeah, colchicine. So
Okay.
it is a very old medication. It works at reducing inflammation through a number of pathways. And as Dr. Mubareka had mentioned, COVID is very unique in the sense that it is as part of an infectious disease, but also part of an inflammatory disease. And many therapies have been dedicated to saying, okay, the virus will get taken care of, but the inflammation that the body deals with to try to deal with the virus from one's own immune system might be causing more damage than good, and maybe what's mediating people to actually get hospitalized or die. And so colchicine is a really novel drug in the sense that it's a inflammatory agent that you can actually take at home without necessarily needing an IV, which is where some of the other drugs have been trialed. And so it could be theoretically given very early to individuals in their disease to tamper that inflammation to prevent them from getting into hospitals. And so the Montreal Heart Institute randomized 4,000 individuals to colchicine versus placebo. They were actually quite unique. They were able to get people within 24 hours of diagnosis and getting the drug to them 4 hours after being enrolled in the trial, which I can imagine was a very difficult job, knowing this could be in the middle of the night. Patients took the dose for about a month, and looking at the entire data set, there were very few individuals that ended up dying or needing mechanical ventilation, although there was a small difference in those individuals. It's still not clear if that's significant enough or just the statistical spread. But when you look at people that were hospitalized, they were hospitalized slightly less when they got colchicine versus getting the placebo. Now, it's not a huge difference, but it's one of our first drugs that can look like it prevents hospitalization amongst a number of individuals. The number needed to prevent one hospitalization is about 70 cases. And so it is certainly promising, recognizing that colchicine has side effects. About, COVID gives you diarrhea, but about 10% more people had diarrhea on top of COVID in this trial. There are a significant number of drug interactions associated with colchicine, and these were excluded from the trial. And so when rolling this out into reality, there may be a few select patients where this may work after they're diagnosed with COVID-19, not before, as this has no antiviral effects. But it has to be balanced in individual discussion based on their ability to tolerate side effects, their ability to tolerate the medication, and their ability to not have drug-drug interactions with other things that they need for their other baseline health.
We only have about 5 minutes because it's been a great conversation. And I want to get in a few more questions. Dr. Bogoch, you sit on the Provincial Vaccination Advisory Board. And this week, we learned the government misreported the number of people who have been vaccinated. How can that happen?
So what they did was they looked at so actually that's not entirely accurate. The number of vaccines that have gone into arms was correct. The number of people that had received both doses of the vaccine was not correct, and then it was corrected. But clearly that's a problem. I mean, you always have to present the correct data, and of course you need public trust in any public health program. And this was a data reporting error that has since been corrected.
It's a big error, though, don't you think?
I mean, I think it is a problem, right? Because I was going to say everyone's watching, but even if nobody's watching, you shouldn't have those errors. You shouldn't have those errors. I think it's also I don't think it impacted, distribution plans. This was really more of a front-facing issue rather than a rear, back-end issue. But it's still an issue. You've got to present the right data in a meaningful manner. Luckily it was identified and corrected quickly. The other data on that website, though, they talked about number of people that had a first dose, number of doses that had been administered. That was all correct. It was that they double counted the people that had received a second dose. Yeah, not ideal. Certainly not ideal. You've got to instill confidence in your vaccine program and present the accurate data. But identified, corrected. Let's move along.
I don't want to labor on this point for too long, but, I think people have been waiting for vaccines as being that game changer. And we've seen the anti-vaxxing demonstrations. Maybe COVID fatigue is happening. There are no vaccines coming in this week. People seem to be losing patience with the rollout. And it's not just provincially, but I think it's also federally, to be fair. Are mistakes being made?
We rely on foreign companies in different countries to produce and send us vaccines. Full stop. I mean, we need access to the vaccines. You can't have vaccine rollout programs in your provinces without access to vaccines. I still think the federal government did a great job in betting on which vaccines we would have access to. Because remember, these decisions were made months ago before we had any phase 3 clinical trial results, and they really picked winners. They truly picked winners. They bet on winning horses because at the end of the day, the vaccines that they bet on ended up being successful in their phase 3 clinical trials. We have, Moderna, we've got Pfizer, we have contracts with Johnson & Johnson, we have contracts with Novavax. These all appear to be very, very helpful. Okay, that's step one. Step two is now we got to get them in the country. which is clearly in the context of an insatiable global demand is proving to be challenging. The program started in mid-December. If we were having this conversation, let's say 3 months ago, people were talking about starting the vaccine programs in the first quarter of 2021. When the government tells me first quarter of 2021, I interpret that as March, but I don't know how you guys interpret it. So, but needles started going into arms December 14th. So yes, it would be great to have more access to vaccines. Yes, it would be great to expand these programs and speed things up. Yes, we should be doing everything we can to get as many vaccines in the country, and once they're in the country, in as many arms as possible, as fast as we can. We absolutely should. Of course, I'm concerned about supply chain issues. Of course, I'm concerned about protectionism and vaccine nationalism and our supply chain. But at the end of the day, we still have access to vaccines. They're still going in arms, and the limited vaccines that we have are going into the most vulnerable of the vulnerable, like into long-term care. And that's 70% of the deaths that we're seeing in the country. So yeah, of course it can be better, but I think we're making do with what we've got and using it in a very meaningful manner.
We have one more minute, and speaking of in the country, Dr. Mubareka, there's news that a Canadian vaccine has started in human trials. How much stock do you put into that?
Well, I mean, any kind of vaccine or therapeutic development that happens domestically, particularly if it's followed up with domestic manufacturing capacity, is exciting. Obviously, it's phase one. We'll have to see what, hopefully it'll go beyond that, and we'll see what phase 2 and 3 show. It'll be challenging because now, instead of being tested against placebo, they'll have to be tested against another vaccine, presumably. So it's not going to be easy or straightforward necessarily. But having said that, I think anything that enhances domestic capacity is good news.
In the meantime, we'll continue to max up, put our masks on, like Dr. Fauci said, maybe 2 masks. I wish we had more time. We had 10 more questions to ask you, but I know you have your busy schedules to go back to, and we do appreciate all of your insights. Thank you so much. We really appreciate it.
Have a great day.
No problem.
Thank you.
Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.